Well, welcome to today's Crisis Jam. I'm David Covington. I'm your host. I'm with RI International and one of the partners in Behavioral Health Link. And today we're really excited about the launch of a simulator, a calculator online that was created by Kana Enomoto's team at the newly minted McKinsey Health Institute. So we're going to be talking more about that tool and bringing on members of her team. But there's been a lot of work over the last couple of years about defining and projecting the volumes and necessary supports for call center services with 988. And we're putting a much more tangible metric to the mobile teams, the 23-hour temporary observation and treatment recliners, and the short-term crisis beds that you would see in crisis facilities by virtue of a newly designed. It's even better than the Excel tool. Paul, is that fair?
Much better than the Excel tool, much more flexibility.
So you're going to see that. We're going to walk you through that, and the McKinsey Health Institute team will be doing that as we get going today. Thanks so much for joining us. Really impressive last week with the Samhsa convening. Well over nearly 700 folks joined that call, but we are getting about 350 to 400 of you who are routinely joining us. Another 100 to 150 are watching the YouTube afterward. So we really appreciate all of you being part of this learning community, not only here to take in, but also to share your own experience and really to accelerate our learnings and our progress all together. If you are with a Medicaid authority and your state is not reflected with that maroon color, then please let us know. We do so appreciate our 60+ national organizations and all of the state's offices of behavioral health joining us. Our newsletter is just on the cusp of breaking 2,500. So while there's nearly 350 to 400 of you in any given week, it's coming from that broader community of 2,500. If you're tracking this meeting online, you can go to talk.crisisnow.com, where you can see all of the materials, the videos, as well as the easily shareable link signing up for the weekly newsletter. And Steph Hepburn shared with Ren and Karen and those of us who help facilitate the meeting that she gets a lot of requests for what's coming up. So we've now added an easy link to the upcoming dates and topics from that page. And you get on the landing page itself a quick view of what happened last week, the really terrific presentation we had relative to the mobile crisis teams in Alaska. So a couple of news items we actually had, and I just added this into the deck for those of you who are in the run of show, but we did have a terrific committee hearing last week. Senator Tammy Baldwin interviewed Assistant Secretary Delphin Rittman about the readiness of states and everything the federal government is doing to support the launch of 988. And Sarah, if we can drop that quick, I know we can share the link for the full committee hearing, but Sarah Corcoran's team did a quick link to a short version of Assistant Secretary Delphin Rittman at one of the highlights. So we'll try to share that in the text chat as well. So big week in addition to that hearing and the Samhsa convening last week. We also had the launch of the 988 and Crisis Services Bipartisan Task Force with Napolitano, Katko, Cardenas, and Stewart. Some of you may remember a trivia question in the Crisis Jam a few weeks ago about a congressional briefing that Colleen Carr and the Action Alliance put on, again, almost 5 years ago, that Napolitano and Katko were the bipartisan co-sponsors of. So we'll have more on the legislation coming out around this when we get to Sarah's update later on. So for our quote of the day, there was, if we go back just a few years ago now, actually back to the 80s, that an individual started to publish monthly a journal in which he shared predictions around the quality of wine based upon an algorithm. Its primary factors were the temperature and rainfall of where the grapes were planted. And people responded to that pretty strongly. They just said that was silliness, self-evident silliness was the, you couldn't possibly determine how good wine was going to be without putting it in your mouth, swishing it around and spitting it out. That was the model at the time. And this is one of those, for those of you who've seen the movie Moneyball, many industries have been impacted by this, but Ian Ayers from Yale, the author of Super Crunchers, also references that story of the grapes, but writes, we're in a historic moment of horse versus locomotive competition, where intuitive and experiential expertise is losing out time and time again to number crunching. So we have today our first effort, Kana Enomoto with McKinsey Health Institute, to begin to put out an algorithm about the needs of communities for core crisis continuum. Kana, most of you know Kana from her long career with Samhsa as acting director at one point, senior advisor with the Office of the Surgeon General, and now the director of brain health for McKinsey Health Institute. And Kana, you're in London for the launch. It's been so exciting watching you and your team work with Samhsa, Nashville, and others around the playbooks and the convening and all the work that you did with Paul Galdus on our team around taking that Excel version, pressure testing it, defining it, making it more rigorous, and putting it online and making it accessible. So Kana, welcome. Thanks for joining us from London.
Awesome. Thank you so much, David. And really, we from McKinsey Health Institute want to thank RI International for the opportunity to partner with them. You know, MHI, formerly our Center for Societal Benefit Through Healthcare, it's a nonprofit generating entity within McKinsey, and our work is not commissioned by clients. Our work is driven by the priorities that we see in underserved and under-resourced areas of healthcare, particularly brain health or behavioral health. And crisis is obviously a hot topic in the U.S. It is an area where we have the opportunity to transform if we play our cards right now. And as we looked around the landscape, we identified the Crisis Now calculator as an opportunity to really bring our tools and our resources as McKinsey to bear for a public good, to create an open access tool and some insights that would be for public use. So we were really excited to partner and collaborate with RI International to support the reimagining and redesign of the calculator. But we certainly, so Paul, Wayne, Kevin, David, Jamie, all fantastic resources and partners to us, as well as others at RI. But as we get to the next page, there were also a huge number of people from the field, leaders, many of you who are on this call, obviously not enough time to thank everyone, but who participated in the design research, the user interviews, pressure testing conversations of the assumptions that are built into the calculator. As many of you know, some of these hard data don't exist nationally or locally. So we did the best we could by talking to the best and brightest in the field to help triangulate on assumptions that would make the most sense for the next next phase of the calculator. I call it a calculator 2.0. I think David has higher ambitions for 2.0, or maybe he already has his mindset on 3.0, but we think that this is a step change evolution of the calculator. Just to clarify for people sort of what the calculator is and what it is not, the idea here is that it will, as we go to the next page, the calculator is meant to enable and empower users to think about the potential healthcare costs of a scenario, assuming that people who need care and should get care would get care. We know that that's not necessarily the situation in every community, but obviously that's the situation we should be planning for and that we should be striving toward. And that's the aspiration for our country. So ways that you could use this is sort of thinking about how would we use and expand existing ED and inpatient sites for communities without alternative resources? How would we adapt the Crisis Now model and adopt it to provide a continuum of crisis services? And then some communities who aren't necessarily ready or ever will do the full Crisis Now model or the standard Samhsa guideline model, could adopt a modified version of BH crisis care. And this calculator gives you the flexibility to pick and choose the components that you would adopt in your system, as I mentioned, based on national assumptions and estimates of the capacity that is needed for each site of care. And just to put it in a context, these are directional, right? Like I wouldn't go build my budget off of it. So like how many FTEs do I need tomorrow? But it is directional estimates, not precise projections. But still puts you in a place to have a sense of, if I had this component or that component, what would it look like in my geography, in my community? What the calculator isn't, it's not intended, as I noted, for estimating the total current cost of BH crisis care. It's not necessarily meant to look across the entire crisis care continuum. So we're focused on healthcare costs in what we're talking about, the crisis continuum component. So not the ones resolved over the phone and not ones that are resolved with kind of regular follow-ups through outpatient behavioral health care. We also aren't necessarily taking into consideration costs of other systems. So for first responders first responders, we're not estimating those staffing needs, and we're not necessarily getting at the ROI from broader non-healthcare savings, though we do have some clear acknowledgement that those exist and should also be a major purpose of implementing a crisis continuum. So this is not to develop detailed budgets or estimate one-time capital investment, because obviously standing these up, a crisis system is both an event and a process, but we are really looking at more run rate costs over time. So with that, I will hand it over to my colleague Nikhil Seshan and Boya Wang, who really did the heavy lifting of crunching the numbers and building the tool.
Thank you, Kana. So this is the calculator itself, and many of you might have used the link that David shared to get to this page. This first landing page summarizes a lot of the information that Kana walked through already. But I think I'm going to do now what everyone's itching to do, which is actually click on the Use Calculator button, which takes us to this landing page. And the idea here is, you see on the left-hand side a map of the entire United States. And so this is kind of the national view that you start off with. And on the right-hand side, you have a comparison of the annual behavioral health costs. And this includes both acute inpatient costs and crisis care system costs. If all individuals who needed in-person care in the US received that care. And so you can see that there's a vast difference between trying to serve that population with just inpatient and emergency department resources, which is what you see here on the left-hand side. And then on the right-hand side is the calculation based on the entire crisis continuum under the Crisis Now model. And so that's kind of what is reported here. I will quickly walk through, what you could do with, let's say, sorry, just give me 1 second. Yeah, so let's say we pick Arizona, and we pick, and we can select, users could select any number of counties, but I'm going to pick Pima just to start off with. And so what you see immediately is kind of the chart updating to reflect the cost estimates for Pima County. And again, these are just healthcare cost estimates, so they do not include, say, first responders, law enforcement, et cetera. And you could, users could pick multiple counties. So, you can add on Maricopa County either by clicking on the map or just including it in the county list here. The one other thing I will say, and what you see at the bottom here is a little bit of the breakdown of costs by site of care, along with a few definitions for folks who may not be as familiar, which isn't most of us on this call. The one last thing you will notice is that there is a gradation of colors here when you look at different counties. And what that is our initial pass at providing a few additional metrics as county and state leaders think about the crisis needs of different counties. So what you have here is the proportion of population in a county that could have behavioral health high needs. And this is again based on outside and third-party claims data where we use to estimate kind of the proportion who might have behavioral health high needs. So it's again directional, but it's hopefully helpful where you see, a county like Yuma might have a higher population that has behavioral health high needs as a percentage of total population, while something like Gila has a slightly lower percentage. And again, the range is close to 1% to 3%. In addition to this metric, you could also look at other metrics like race and ethnicity, or whatever else might be relevant to the decision that you're making. With that, let me pass it on to Boya, my colleague, who will walk through sort of some of the assumptions that are pre-populated, how you can change them, and some of the modifications that you can make to this.
Perfect. Nico, if you want me to, let me share my screen.
Sure, absolutely.
Okay. Great. Perfect. So as Nico mentioned, now we're in the module where we can edit assumptions. So for those of you who are familiar with the Excel version of the calculator, you will see that these two assumptions here, they're exactly the same as what you could previously modify in the Excel version. And then you can see here we have already pre-populated with some existing data. So we've actually done claims analysis at the state level. So the numbers that you're seeing here are populated based on Medicare and commercial claims at the state level. We would have liked to also include Medicaid claims, but as you probably know, Medicaid claims are kind of messy at the state level. So that's why here we're just doing Medicare and commercial. And you can easily change these numbers. So for example, if I change the average cost of an acute psychiatric bed to $1,200, you'll be able to see the cost will change accordingly on the right-hand side. And then we also have a toggle that can let user choose whether individuals can be triaged to inpatient directly from other sites of care without needing to go through the ED. So based on whether the user chooses yes or no, the utilization of ED will change, and then the cost on the right-hand side will also reflect accordingly. So moving on, so in this example, I have chosen Maricopa and Yavapai. So here we're laying out some of the assumptions at the county level. And I would say the most important thing is the travel time for our mobile crisis team. So we have worked with our geospatial analytics specialists to come up with a pre-populated travel time for each county. And of course, if a user has a better idea of what the travel time could be. So let's say if for Yavapai, I think it's 120 minutes instead of 66, we will be able to see the MCT episodes served per day will change accordingly on the right-hand side. And then, and I think later in the demo, you will be able to see the capacity needed for MCT will also change. Cool, so these are the most fundamental assumptions. And then we've also incorporated the ability for users to edit additional assumptions. So any costs associated with short-term crisis bed, crisis receiving chair, ED visit, and also assumptions on average length of stay and occupancy rate, the user could also change very easily in this module. Cool, so moving on, I would say probably the most interesting feature with our calculator is the ability to add a third scenario, which is the modified scenario. So there are two ways to do it. The first way would be to choose which sites of care the user is interested in adopting. So for instance, so here we're laying out the 3 core elements of the crisis now model. And then let's say if I were a user who thinks, okay, like I probably don't have the resources to implement all 3 elements, like maybe I just want to do crisis receiving facilities and mobile crisis teams. So then I will be able to see on the right-hand side what the cost is associated with this specific scenario, and then also the cost associated with each site of care. And then the other way to do this would be to edit the. Oh, sorry. I think there is some echo, but okay, I think we're good now. So the second way to create a modified scenario is to edit the utilization assumptions directly. So for someone who's like, really advanced, who knows exactly what the utilization assumptions should be for their community, they can directly edit the assumptions on initial triage and also the referral rates from one site of care to another. Perfect. So this is to add a modified scenario. And then moving on, so then in the next modules, we're displaying the capacity needed. So here in this table, you can see the capacity needed in each scenario against each site of care. And then I would just highlight that here, the potential capacity estimates for inpatient beds do not include extended psychiatric stay beds. Cool. I think this part is pretty straightforward. And then moving on to the next module here. So here we're estimating the potential differences in utilization between a user's current state and the crisis now model. So we created this module because from our design research interviews, we heard a lot of people say, okay, like they want to understand the human case for implementing BH crisis care. And they want to understand if the individuals in their community are getting the appropriate level of the care that they need. So here in this module, the user could compare for the existing sites of care in their community. Are they over-serving or under-serving compared to crisis now? So in this dummy example, I have put in, let's say in this example, the mobile crisis team is serving 20,000 episodes. And then we have 30,000 episodes in our ED, 40,000 episodes in our acute inpatient bed. And then on the left-hand side, you will be able to compare and see, okay, my mobile crisis teams are under-serving, so maybe I should invest more in my MCT. And then one last thing I would note here is that, let's say for a specific user, if they don't have readily available the data on the monthly episodes, they could also provide estimates on number of beds they have, and then average length of stay, and then occupancy rate for this calculator to help them estimate how many monthly episodes are being served in their community. Perfect. And the last 2 things I would demo here is that we have added a functionality for users to explore everything into a PDF, so that they can easily share this with their colleagues and other stakeholders that might be interested in learning about implementing BH crisis care. So in this PDF, we have an overview of what the calculator is, and then basically just printing all the output that's been generated and all the assumptions that the user may have modified in the calculator. Cool. And then lastly, I will just point to the FAQ. So we have a pretty detailed FAQ on the context of the calculator, and also, I think more importantly, all the methodologies and the formulae that went into creating the calculator, and also the sources for all the assumptions that have been leveraged. Perfect. I'll pause there and just wanted to say I'm really grateful for everyone who has helped us on this journey, and I'm really, really excited for all of you to use the calculator.
Thank you so much, Boya. Just terrific. And Boya, thank you. You're joining us from Greece, I understand. So I really appreciate you taking time. Kana, Nikhil, the Excel tool that we visited frequently in the Crisis Jam over the last year, where Paul and Tom Betlock would make comments, certainly brought some capabilities, but the extension of this, the rigor that your team kind of put to the data, to the testing, to bringing other users into the experience, helping make this much more accessible, showing our math on this model. Just love all of this, just terrific work. And this doesn't happen without the investment of McKinsey Health Institute to bring this to the public domain. So thank you so much. So let's start with Jamie Michael from Doñana County in New Mexico, who is one of the people that your team met with to push on this. Jamie, welcome.
Thank you, David. I'm happy to share some reflections with everyone about my experience with the Excel spreadsheet initially, and now with this new, more dynamic tool. I am the director of a local county level health and human services department. I am not a data tech person, but I need data to make decisions around planning. We have a crisis triage center. We're in the midst of 988. So this data is important for our planning and the operations of our department. It's also really important for me as I'm communicating with local elected officials who make policy decisions and financial decisions about investing in these types of services. So I've got to say, over the past years, that Excel spreadsheet was a page that I refer to very often. So the data that is included is really important. It's really valuable in communicating the model, communicating the impact. So first, I think I'm glad that all of those data points are there. And if it was that helpful in an Excel spreadsheet form, I'm really excited for how helpful it's going to be now with this new tool. I think some of the things, again, that make this new tool so valuable to me is that it's simple. I'm not a data tech person, but I think this tool is a great balance between being very flexible and dynamic. I like being able to change some of the inputs, but it's also very simple to use. It's not intimidating to jump in there and start exploring what things look like in my county, what they can look like in my region, including other counties, and what they can look like in my state. So I really like the ability to have a lot of the work already done for me with a lot of the data pre-filled, but then being able to manipulate that a little bit and change some of the assumptions. The other piece I like is how visual it is. Even if I know that the numbers may not be precise, the visual representation with the graphs and the charts really help paint a picture for our elected officials and help lay out what the crisis model looks like and how the components all impact and are kind of connected to each other. So all around, it's a really useful tool. I encourage people to use it, and grateful that you all did all the legwork for us to make our jobs easier. Thank you.
Terrific, Jamie. Thanks so much. You know, I'm watching, there's just an amazing amount of content in the chat, and a number of questions around the applicability to child and adolescent, some of the questions about the underpinnings of how the mobile crisis components work. So there's a lot to bite off here and chew on. Paul, we want to make sure that we come back to this group with an analysis of everything that's going on in the chat text and try to speak to as much of that as we can. But let's go to Brian Hepburn. Brian, this very much was your brainchild back in 2017 when you first asked for a business case around Crisis Now and challenged a number of us to begin thinking this through when no algorithm Models are a dime a dozen, but you have to have one. And we did it in 2017 when you first started this charge.
Yeah, thank you, David. And I think that was a big improvement compared to what we had previously. And now this is, I think this has just hit it out of the park. So thank you to Kana, to Nikhil, and to Boya for their presentation. And I agree with Jamie, this is very exciting. I think RI and McKinsey has really done a really good job on developing this tool. I do want to emphasize this is a tool. Really underline what Kana was saying. Be careful. We don't want to overpromise on this. We don't want to go to the budget office and tell the budget people, hey, we've got a way to save all these millions of dollars, because they'll start planning on how to use that money before you've saved it. So we do have to be very conservative in that way. States and local jurisdictions will be able to use the calculator. It will help them with their planning. States will be able to use the information to advise their executive branch and their legislative branch. And again, advise, estimate, not promise. The key questions related to cost and capacity will be very helpful. It will also help to clarify the cost effectiveness of the new crisis system as compared to the current crisis system. I want to also say that, can't read my writing. Oh, it was just basically saying, underlining Kana's caution. And I did want to say that one of the concerns in terms of the modeling is that we're hopeful that Crisis Now will really decrease the number of people that are going to jail. A certain proportion of those people will end up going to the emergency room and to inpatient. And so as we go forward, those are costs that will be saved, lives that will be helped, but there isn't a good way of adding that into any model at this point. So I would say that it will be very important to be updating the model and to make sure that this isn't seen as a one-time only. We're going to have to add what we're learning as we go forward to make the model better. So, but this is a great step forward. Thank you, David. Thank you to RI. Thank you to McKinsey.
Thank you so much, Brian. And again, thank you, Kana and team. This is the inclusion of the vulnerable populations database, the ease of use, the showing our math through the FAQs, the visual components Jamie was talking about, and then this ability to stepwise, call it a modified scenario, but let's say you want a roadmap step by step through some of these components over time. You can track that, print it all off in this estimate. The one thing coming back to, again, we certainly believe there are savings with Crisis Now. However, that primary, when you go to that map and it shows you the differences, what that's showing you is we have to serve everybody in need. And based upon our understanding of what that need is, you're either using the existing chassis you've got or the components of this Crisis Now model. And to the extent that you follow that all the way through, those are the costs that would come out of that in terms of our best estimate. So Kana, any last reflection? Again, a whole lot of stuff in the chat text that we're going to want to reflect on as a team and loop back with this group. But any other final comments, Kana?
I think just to follow up on your point, David, about, cost is an important factor, and we do want to show that we can save money, or we can at least be neutral on the expenditure versus the savings. But at the same time, as all of you know, we don't just treat cancer because it saves money. This is about saving lives. This is about helping communities figure out a path to better serve people and to save more lives, frankly, and to reduce human suffering. And so I think we try to capture that in some of the FAQs and other documentation here, but we should not lose sight that that's really the purpose of all of this. It's not just to save money, but to better serve people who deserve to be treated with care and compassion.
Well said, Kana. What I'm hearing you say is at the end of the day, this calculator reflects a sea change in the approach to crisis care. And that's reflected in the Samhsa National Guidelines from 2 years ago of we serve everyone, every time, everywhere when they're in a crisis. So this calculator gives us the pathway to do that. So more to come on that. And actually, we're going to get back to the McKinsey team because the Crisis Talk article this week is also with this same team. But now I see Jen Stuber and Rep. Tina Orwell preparing in the green room for the Crisis Trivia Hot Seat. You're so close. We're almost there. We have one little segment that's going to take a couple of minutes, and then you guys are ready. I see you're ready. But let's first go to Dr. Thomas Joyner. We've been highlighting the Moving America's Soul on suicide, and we've been highlighting the Tanja Miles amazing story over the past weeks. But we have already published the Silouan Green story of a former Marine. Boy, I'm loving the beard, Dr. Joyner. Oh my God, the COVID beard looks amazing on you. Wow, okay, I was distracted. All right, we've had Kevin Berthia's video out there. We just published Dr. Ursula Whiteside's story. And just in the last few days, Dr. Joyner published from when you can see a lot of fans in the Florida State Stadium there because of COVID. But Thomas, give us a couple of thoughts on the work that you and I are producing together with our filmmaker, Justin Shelby.
Yes, well, thank you, David. Great to be here. Great to see everybody. David, am I coming through? Can you hear me?
Yes, sound great.
That's good. Yeah, well, as to the beard, it's not popular with everyone, especially on the home front. So it's going to be short-lived. I can tell you that right now. But as to the film series, this is an effort. I like the comparison, as I know you do, David, to past public health success stories where we can learn something. And Kana mentioned cancer. That effort of tobacco use and cancer in the United States is interesting to think about. It was multifaceted. There was involvement of funding, government funding, private funding. There was science for sure, front and center. And there was activism and grassroots advocacy. And I view this effort, Moving America's Soul on Suicide, this series of short films, as one such advocacy or activism effort, trying to reach out to more and more people to have them understand the poignancy of some of these stories, and also the hope reflected in some of these stories. And so I'm happy to be a part of it. As David mentioned, it's a collaboration between him and Justin Shelby and myself. I have to give most of the credit to David and Justin. They've been amazing, flying around, capturing all these great stories. But the idea is storytelling as a way to promote activism and advocacy. There's a lot of ways to do advocacy and activism. There's a place for litigiousness, even like in the tobacco wars, there were lawsuits for sure. There's a place for that. There's a time and a place for stridency and litigiousness. There's a time and a place for that. This is not that. This is inspiration through true, credible stories of suffering and of rebound and hope. And so I'm happy to be a part of this, David, and I thank you for letting me be a part of it. And I hope it does, add to the momentum on moving people's attitudes on this really urgent public health matter.
Thank you so much, Thomas. Really appreciate you joining the jam and sharing. And we're soft promoting it right now. It's just more inside this community. We're working with our partners at the National Action Alliance for Suicide Prevention with Colleen Carr and Company, and also with the Dr. Draper and the group at Vibrant Emotional Health. We plan to do more significant promotion when we've published all 9 stories. And in fact, one of those stories, we did visit Kana and her daughter Raina back, which that story is Kana's still coming in the weeks ahead. So great. Thank you, Thomas. Let's go to the green room. They're live, Rep. Orwell and Jen Stuber. We've got one of our Democratic leaders from the House of Representatives and an associate professor in the School of Social Work at Washington State University, Jen?
UW.
Oh boy, I just walked right into that one. Yeah, and the founder of Forefront Suicide Prevention. I'll just keep moving right along here. We're glad to have you guys. Now, this is, I thought these are great partners and we've got a tough question today. But look, you've got your friends in the audience and you can phone a friend if you need to. And the answer was in Boya's presentation several times of the calculator. But traditional, we talked about the Erlang C, and I saw a note from Suzanne in the chat text about did we do something similar to mobile? Not as sophisticated as the Erlang C, but yes, Suzanne. But we have those algorithms in all of these tools, right? And they have to do with the same kind of concepts. And today we're going to talk about throughput. Traditional psychiatric facility models, we've often seen leaders focus on, they'll use the language heads in beds. 988 prompts us to think more about serving more people, serving them more effectively. How are we going to really transform communities? What are the elements in the crisis receiving facility equation to determine throughput? A, census and recidivism rate. B, census and door-to-doc time. C, census and voluntary status. Or D, census and average length of stay. So we're going to start with giving the audience a chance to share their thinking with you. So you'll get that into the equation. So audience, if you can all pick one of these and click submit. And we're going to give that about 10 seconds. And then Karen is going to bring up our audience view of this. And you guys, you can go with the audience or you can decide to call in a friend. I've seen some friends in the text chat who 100% know the answer to this. I can't give you who they are. That'd be cheating, Rep Orwell and Jen. Let's see the results. All right, so the audience overwhelmingly thinks it is D, census and average length of stay. But there are people answering all of these. So phone a friend or make an answer. Rep Orwell, Jen, what do you think?
We would like to call Paul.
Paul was part of creating the question. So Paul is one of the it's a good try.
We had an idea that might have been.
You can call, I tell you, I'll give you a hint. Dr. Margie Balfour is on this call and she was not part of the question. You could call her if you like.
Margie, are you available for a call?
I am available. I'm unmuting myself right now.
And Margie, you were part of the inspiration as I was thinking of answers on this.
Yeah, so I would say that it is D because it's how fast you get people through. If you don't get people through fast enough, then they're going to back up. And so it's how many people you have there plus how fast you're getting them through, which should be your average length of stay.
Wow, and we also have an extremely smart audience who said the exact same thing.
Exactly.
So we're going to go with D.
We're going with D.
And the answer is D. So
it's done here today.
And Margie, I don't know if you would agree with this, Margie. I was thinking through options and the amazing work you've done on door-to-doc time. It is a proxy for driving how throughput can be better. It's not fast for faster's sake. It's about meeting the person's needs in the moment. And Margie, you've done amazing work to make sure that we do that in the most efficient way possible.
Yeah, we've done, I'm a big lean process improvement, nerd. And when we've done, and our work has shown that the door-to-doc time is a key metric because all these other things cascade from it. So when you have, and we try to keep ours around 90 minutes. And because the faster you get someone seen, the faster you can start treatment. And so we see that seclusion restraints go down, assaults and injuries go down, the total length of stay goes down, and the percent of people that you can discharge home and versus a hospital goes up. So that's a key. It's a door-to-doctor time is like a really key metric, but for the purposes of which really influences your throughput, but the actual throughput's defined by that average length of stay in the census.
Hey, and Rep Orwell and Jen, this is the first duo for a Crisis Trivia Hot Seat. You knocked it out of the park. Great, great work. Hey, and look, we've had trouble roping people in. Nobody wants to be under the spotlight by themselves, but as a team, hey, that was fun, right?
Absolutely.
No, very honored. Yeah, thank you.
So if there are duos out there, please let Karen know that you'd like to be in the hot seat, and we'll bring you in. So thanks, Dr. Balfour, and thanks everyone for joining us for that version. So let's go to this week's Crisis Talk interview, which is back again to the calculator. We usually stagger these, but Steph, we decided to launch all this at one time. So Steph, you really went through this in detail.
I did. Yeah. And I don't know if it's going to be Kana or Nikhil or both chatting with me. But it would be nice to flesh out the analysis behind the estimated prevalence rate, if somebody can talk us through that.
Yeah, I believe Nikhil's going to do that.
Okay.
Sure, I can do that. I'm a poor substitute for Kana, but you know, I'm sure she can jump into. But I think Stephanie, the thing I enjoyed many things about the article that you published. But I think the thing that you did so well was really articulate in a couple of pithy paragraphs the methodology around the prevalence calculation. And the kind of 45-second summary of this is we entered this effort, sort of we staggered it into three pieces. So there was a refinement piece where we tried to pressure test assumptions in the Excel calculator as much as we could. And then there was a little bit of the redesign and the reimagination of this as a web tool. And so in the refine phase, one of the biggest pieces of sort of pressure testing was the original estimate around 200 episodes needing in-person behavioral health crisis care every month for every 100,000 individuals. And so this is kind of our starting point. But the way we approached it was a little bit clean slate. So we did a top-down analysis where we took Vibrance estimates around the potential serviceable population for the 988 hotline. We then multiplied that by published estimates for the number of calls per person that could be expected. And again, I think we'll have much better data, you know, once the hotline launches formally on July 16th. And then we multiplied those two numbers with a 10 to 20% estimate for how many of those in-person callers would need in-person care. And so some of the questions that came up in the chat, which I really loved the engagement throughout, were around like, you know, are we thinking about the call center and all of those costs? And the truth is this calculator is a little bit agnostic of like the call center, but the prevalence assumption is how, you know, there's a tie-in to the 988. So this is literally all those people who we estimate might actually need in-person behavioral health care. So that was a top-down estimate. And that got us to about 200 and, you know, between 220 and 230 episodes per 100,000 individuals per month. And then we did more of a bottom-up estimate, which is we looked at national claims data. So a lot of this was Truven data for commercial Medicare and Medicaid. And in this instance, we could use Medicaid because this was just national data, not state level. And then we said, how many emergency department visits, how many mobile crisis, you know, claims, how many crisis receiving facility claims are we seeing? Knowing full well that there is a little bit of an underreporting there, perhaps, because a lot of mobile crisis teams probably don't even, you know, file claims, given the differences in reimbursement. But we took all of that data and then we added on the, I'm sorry, this is less of an interview and this is more of a presentation. I will stop. The last thing we did, Stephanie, was we added on using the Treatment Advocacy Center's Roadrunners report. We added on the proportion of all kind of emergency non-healthcare first responder pickups that did not get transported to in-person healthcare facilities. And that kind of also came to the 230 number, which is why we updated the original estimate of 200 episodes to 230 per 100,000 individuals per, you know, who needed in-person care.
So Steph, we're going to move on, but there's a lot of there's a lot of detail in your article, and we've got a tremendous number of questions in the chat text that we're going to come back to. Look, if your question wasn't answered today, Karen's going to go through all of these, and there's a lot of detail in Steph's article as she walks through this, and you can hear from Nikhil in the thinking that went into the rigor behind the math. Model, you know, John Franklin Sierra says all models are wrong, but some are useful. You got to show your math, which is what Nikhil was starting to do. So more on that to come. Dr. John Palmieri, wow, what a week with the Samhsa convening and Assistant Secretary testifying and more. Give us an update.
Thanks, David. Yeah, always a lot going on, and it seems to be accelerating kind of exponentially. But wanted to thank you, Brian Nashbid, Kana, a host of other partners for a very successful convening last Thursday, focused in on 988 readiness across a number of audiences that we think are critical to successful implementation. We had the opportunity during the convening to share a vision tied to some aspirational benchmarks across the crisis continuum to emphasize really the importance of an all-of-government, multi-sector approach with respect to leaning into those partnerships and implementation supports. We heard about federal activities in the crisis landscape, and we're able to share a high-level view of playbooks to support implementation. Really appreciate everybody's hard work in making that possible. Felt really good about the participation of hundreds of partners and organizations, and expecting that those playbooks will likely, Brian may have more information about this, but likely to be available sometime early in April. And we're engaged in ongoing planning with respect to learning activities, again, in support of implementation. Also, just wanted to flag a couple of other things. One of note is the release of the Samhsa FY23 Congressional Justification, which you will see in there our request of $10.7 billion for Samhsa, which includes a number of areas that are relevant for crisis services, including nearly $700 million for the 988 in crisis services consolidated program, along with other items of note that obviously where there's obviously a lot of intersection with crisis services, including the mental health block grant, community mental health centers, CCBHCs, and the state opioid response grant, among others. And then also just wanted to note the formation of a new bipartisan House 988 and Crisis Services Task Force, which will live under the Congressional Mental Health Caucus. And they're focused really on access to care, improving health outcomes, cost savings where possible, and reducing unnecessary burden on law enforcement. And we're really looking forward to that ongoing engagement and partnership with the task force, and see a lot of opportunities for continued education and technical assistance there. And so now I'm going to pass it off to Richard to see if you have any additional comments from Samhsa.
Hello, John. Thank you very much. I'm on an Amtrak train returning from.
Yes, I was on that train yesterday.
Great meetings of a lifeline. We met with Vibrant for a 2-day site visit meeting regarding 988. It went really well. So as not to annoy the other passengers, I will not go into anything further. But as John mentioned, just amazing work being done at multiple levels. The transformational impact of 988 is really starting to become visible in many different places. So thanks.
Love that, Richard and John. John, there's a number of people in the chat text asking about some of the slides from the convening. Is it possible for others who weren't engaged to see? I mean, just thinking about those horizons that you were talking about, John, of the goals and some of that content. Is that available for others to see at post the convening?
Yeah, David, we just needed to make a couple of small adjustments to the slide deck, but then we're going to make it publicly available. So that should be forthcoming.
Terrific, terrific. Okay, let's go to Dr. Brian Hepburn and the Nashville update.
Yeah, thanks, David. And just real quickly, thank you to Samhsa for its leadership. The 988 convening last week was tremendous. I think every state was represented. Next slide, please. I just want to highlight a couple of things that Sharon Hoover has done. One is the Crisis Now, Crisis Talk article on how schools are stakeholders in mental health crisis. And Megan is going to put that in the chat where you can find it. The second is the Beyond Beds article, improving the child and adolescent crisis system, shifting from a 911 to a 988 paradigm. The reason I want to highlight Sharon's articles and her work is because she's in Poland this week, and she's helping with the refugees from the Ukraine. And I wanted to just quickly read an excerpt of what she sent. It's day 3 of my time in Poland. I wanted to provide an update and express my gratitude for the support of the effort. Collectively, with the support of generous donors, we have translated and proofread more than 17 evidence-based psychological training and triage documents into Polish, Ukrainian, and Russian. approximately 1,143 pages of text in less than 3 weeks, more than 27 translators, including many volunteers from 7 different countries, in addition to the people from both the middle and both coasts of the United States. She is joined by Dr. Kira Mosseth from Seattle University, Dr. Tona McGuire from University of Washington, Dr. Eric Bruns from the University of Washington, and Robin Smith from Washington Behavioral Health Strike Team. They're all there in Poland. She goes on to describe a little bit more of what they do, but because of our time, I just want to leave you with her last statement. She said, "In the context of the horrors that we are hearing about, I am most struck by the humanity, charity, and grace of the people that we meet and the strength of the human spirit." And I wanted to share that because I think that describes the people on this call as well. So thank you very much.
Oh, that's terrific, Brian. Humanity, grace, and strength of the human spirit. And great to have one of our Crisis Jam presenters and learning community partners involved in that effort on the front line. Let's go to Sarah Corcoran. Sarah, update around everything going on now with the president's budget and more.
Yeah, and thank you, David. We are debuting our new graphic here today in light of a lot of congressional activity, as we've been talking about for the past few months on mental health and substance use, as well as that really strong FY23 president's budget request that came out on Monday that Dr. Palmieri mentioned. Samhsa numbers and overall HHS numbers are just very impressive. Such a huge focus on implementing 988, as well as really trying to connect those gaps in mental health and substance use access currently. So it's a great document if anybody wants to look through it, but we've got some outlines of some of the items in the budget request on the left here. One thing I will focus on specifically before I turn over to Joanna is an upcoming House Energy and Commerce Committee hearing that will be on April 5th, and it is a legislative hearing. And I would just wanted to flag that there is a new bill that is worth looking into, HR 7323. That is the 988 and Parity Assistance Act, and that is a Cardenas bill. So less than 2 weeks after the bill was introduced, that 988 implementation bill a few weeks back, there was an opportunity for Energy and Commerce to consider the bill as part of a Samhsa and HRSA focused hearing that they are having on the 5th. Because of the focus on those two agencies, they needed to introduce a more narrow version of the bill with just sections from those two agencies, given the focus of the hearing. They thought it was the best way to move something forward, given the upcoming July implementation deadline. So it is a fantastic effort to try to move some of those provisions in a bipartisan manner, while they're still, of course, focusing on figuring out the best avenues for the other provisions of the bill. So that also includes the Cardenas and Fitzpatrick parity bill, combined with some of those HRSA, SAMHSA sections of the 988 bill. So a lot more to come on that, but really exciting that so soon after the bill was introduced, it has now been officially noticed as part of that April 5th hearing. And I will turn to Joanna now on the rest of the committee updates.
Sure, yeah, so Secretary Becerra is going to be joining the House Appropriations Labor HHS Subcommittee tomorrow, kicking off, as Sarah had described it to me, the tour of congressional committees on the FY23 budget. So he's going to be testifying on the President's FY23 budget proposal there, and then again, next week on April 5th, I believe, is the Senate Finance Committee. They're also going to be hearing from Secretary Becerra on the HHS budget. In terms of more hearings, there's also one today that I believe is probably wrapping up at this point from the Senate Finance Committee on parity in behavioral health care. So that's what's going on in the Senate finance world and the House finance world. So I'll turn it over to whoever's next.
Yeah, so thank you so much, Sarah and Joanna. Steph, are you with us? We've got less than a minute left just to give a directionality around the states.
Yeah, sure. I will just mention a couple quick highlights. West Virginia is really the major change on the map. They had their Senate Bill 181 signed into law. This is just a bill that defines crisis hotline center standards and outlines a few funding requirements, but really still wrapping up a lot of state legislatures will be kind of wrapping up their sessions over the next few weeks. So we'll kind of see which bills get over the finish line here shortly.
Terrific. And Jordan, apologize for not getting to you today. We'll make sure to give you some time this coming week. I believe Dr. Brian Samhsa is our host, and Tim Marshall will be on a lot of questions about crisis care for kids today with the amazing program in Connecticut. Thanks for all of you for joining us, especially thanks to the McKinsey Health Institute team and to Rep. Orwell and Jen Stuber, who are in our Crisis Trivia Hot Seat. Take care. See you next time.